Pleasant morning to everyone who's online, remotely. We're going to talk about COVID-19. We're going to talk about testing and the measures and everything related to it. Today's discussion, of course, wouldn't be possible to conduct without the support of AmCham in cooperation with ROCHE. And I'm happy that I can welcome esteemed guests, Alexandra Bražinova, epidemiologist from the Comenius University, Boris Klempa, virologist from the Slovak Academy of Sciences. Be welcome, and Patrik Danko from ROCHE, Slovakia. Welcome. Brief instructions.
You can switch the language to English. It's on your right hand. You can see there is a sign for switching the languages.
And for everyone who would like to join the discussion, we'll be also asking the questions that you put through Slido, hashtag COVID testing. And of course, you can see this also on your screens. And right for the start, we have a brief, survey, so to say. Tell us whether you are planning to get vaccinated against COVID-19. Well, I hope most of you say yes. Hopefully we agree on this. But let's start right away. Ms. Bražinova, let me start with you. How are we doing? Simply said. Well, we're still not doing very well. We're doing poorly. We still have high figures of hospitalized patients and high figures when it comes to COVID deaths. Even though to fuse a little bit of optimism, in recent days the epidemiological situation is improving or has been improving slightly. We've seen a slight decline in the number of 7-day average incidence. Of course, the situation is different across the regions or across districts, but so far, we don't see this in the number of hospitalized patients and the number of COVID-related deaths. So we expect that these improvements in the figures are a result of the so-called harsh lockdown or strict lockdown as of 1st of January. But we still have to wait at least 1 or 2 weeks so that this reflects on the number of hospitalized patients. We expect that at the end of January, beginning of February, the situation should be improving much more significantly as long as we stick to these strict measures as they are at the moment. So the government still maintains that this is going to apply for the next weeks, so we don't expect this to change. Much has been said about this strict lockdown, that it should be working better, that it seems that we either don't have this lockdown so efficient or effective because it's not controlled, or something might have changed because of the mutations. What's your take on this? Well, the answer is slightly limited by the data we have available. The monitoring of situation depends very much on the number of the performed tests, number of PCR tests, antigen tests. So the daily numbers and the 7-day or 14-day incidence pretty much depends on this. But the reliable data reliable indicator are the hospitalizations and deaths. And for those, you need a longer time. I mean, so that to make sure that the lockdown really works as we had expected, you need at least 1 month from the beginning. So in other words, we will know reliably at the end of January, early February, whether this lockdown really works. Mr. Klempa, we mentioned the mutations. We know 3 mutations. Of course, we don't want to blame the countries, but they are named according to those countries where they were detected. So there's Brazilian, South African, and British mutation. People don't really understand this. So let's start to define. Let's start with the British mutation, which is in Europe, and it means that the COVID is spreading faster. However, it's not more deadly. It's not more deadly. So what's your take on the British mutation? Yeah, just the word mutation is slightly misleading. We should rather call this British or English. It is politically incorrect, however, it helps to identify what we're talking about. So we should be calling about strain or variant, viral strain or virus variant, because in fact, this is a viral strain. You know, virus has a number of mutations, so you can't talk about a single mutation, a British mutation or English mutation. I would rather say a British strain. And this strain, you know, the mutations are accumulated continuously in the virus, you know, since January last year. It's quite normal, but this strain is significantly different that firstly, there's more mutations, and they are not evenly distributed across the genome, but they are concentrated in this important spike protein, this spike protein that codes the spike, and this is where several mutations are concentrated, which are attached to the quality of the linking of the virus to the receptor in the cell. So, in other words, the virus has a better key to get inside the cell, put in a layman language, and this relates to this higher infectious rate. In practice, better infectious rate or better rate of infection means that I see two major reasons why this is so. Thanks to the better binding of the virus to the cell through the spike, you need much smaller dose of the virus for this infection to be successful in your organism, because it's not like the one virus gets to you and you get sick. No, you need much more than that. And on average, the infected people have more of this virus in their throats or lungs. This is what we said during the first wave, that the virus may mutate and it may be spreading faster. Yeah, this is a natural evolutionary quality of the virus. The evolution doesn't push the virus to be more deadly, because from the evolutionary perspective, this is disadvantage for the virus, because the virus dies with the host body. But much more likely are going to be the mutations that improve the spreading, and this is exactly what happened. With this British variant, it's much more advantageous for the virus, and all of these mutations have one common denominator as the mutation of the S spike protein, and many of them are exactly in the binding location, and that's why the binding is more efficient. And the second thing is that these binding locations are also full of these antigens, and that's why that's why it's more difficult to identify the virus. So if I overcame COVID in past months and I have antigens, these antigens do not have to be so efficient with the British strain compared to the original strain. Yes, this may be so. However, these are things that we expect from the Brazilian strain. This is the most fearful, so to say, because in Brazil, in the city of Manaus, there's been an increased number of reinfections or reoccurring infections, repeated infections. With this British strain, this is not the main concern. The main concern with the British strain is the more intensive spreading of the virus, which will cause just larger number of absolute figures of the infected individuals, and this, of course, results in the number of other problems. With the South African strain, we also expect increased rate of infection, and also the possibility of increased likelihood of repeated infection and reduced efficiency of vaccination. Talking about the South African, we expect this. Much is being discussed about this. The data is gradually incoming. There are various types of data, and certainly some limited ability of neutralizing the virus have to be expected. But so far, we don't expect this to be absolutely making the vaccines dysfunctional. There may be some reduction in the efficiency of the vaccine, but we need to be thinking about what is the definition of efficiency of the vaccine. Preventing a serious disease will still be 100% perhaps. Similar to flu vaccination, that you get a light version of the flu, but the flu is not going to be so difficult, right? Mr. Danko, how this can influence testing and vaccination? Well, these, antigen tests can still detect the British strain or South African strain, etc., etc. How the pharma companies are preparing for this? So far, it applies that these mutated forms of these mutations that we have here can be detected even through the PCR tests, conventional PCR tests or antigen tests. they can detect them quite reliably. When it comes to testing, we can detect, yes, this is COVID positive patient, then we can perform a test which detects any particular mutation. So companies are ready for that. Of course, the development of the virus or evolution of the virus can be different. You know, mutations can be numerous with time. And I believe that testing can be also impacted by these slight changes of the virus. Impacted in what sense? You need to update the vaccine. You need to update. Yes. Ms. Bražinova, what this means for the conditions we have today, conditions of lockdown and the conditions of contact. You know, so far we say close contact is 15 minutes without face mask of less than 2 meters. But because these strains are more infectious, shouldn't we redefine these rules we have introduced in companies and stores that 2 meters is not enough? Perhaps we should only use respirators instead of face masks. They do this already in Austria. So how will this change the definition of what we live today, what we are living today? Yes, it is possible that these contact settings will have to be redefined. So far we are considering this, and it still applies that any strain or variant of coronavirus to slow down its spreading in the population, the most efficient measures are reduction in the mobility, so reducing of meeting with other people, minimizing the contact with other people. And yes, I heard experts saying that this 15 minutes rule, like if I'm somewhere up to 15 minutes, the risk is minimum, and over 15 minutes, it's higher. Well, this rule is slightly outdated. But, you know, it's quite difficult to define when I'm getting infected. It can be a question of a minute, you know, or less. But knowing that these new strains are more virulent, more infectious, we need to be paying even more attention. So the measures we have already implemented are the maximum we could implement. But each of us individually can be more responsible. So I can minimize the, my exposure to the infection by not going to the shop 3 times a week, but just going once a week. Or everywhere I go and there are other people, I will be very consistent with wearing a face mask or a respirator. So you need to be even more careful than before. And the fact whether we redefine the 2-meter distance or the length of contact, that's premature. I mean, it's possible it will happen, but I can't be definite. I would say, in this sense, I perceive it, and I see in Austria, in other countries where they are implementing this, there are people who are experts. But to me, it seems that this is a declaratory thing, like it's here, we need to change something, But from my perspective as a virologist, I believe that the measures that have already been set, like the 2-meter social distancing or the length of contact with other individuals, these are not data that we calculated based on some qualities of the virus. This is about physics of these little particles that the virus used for spreading, aerosol, And if 2 minutes is enough, then it doesn't really matter what kind of virus is in the aerosol, which is on the particle, whether it's a coronavirus or it's a flu virus, it doesn't really matter. So I wouldn't really expect much from changing of these rules. I mean, naturally, a respirator is much more efficient than the face mask from cotton. And this includes also mutated coronavirus. So from my perspective, nothing really changes because it's all about these little particles in the air. I mean, the virus is absolutely passive on these particles. It is not moving on its own. It cannot, penetrate the face mask on its own. It can only be a passive traveler on these particles of aerosols. And if we manage to stop the aerosol, well, then it doesn't really matter what kind of virus is there. Well, now we have people from companies watching us. So it doesn't really matter if you go to the shop or meet other people or don't, but let's focus on plants and factories or companies where you just simply can't have home office. I mean, we have automotive factories and people have to be there physically to assemble cars, right? And other companies as well, of course. So, Ms. Bražinova, what an employer should do talking about these new strains of virus? I mean, the things that you do today, that the shifts are not changing, so they are not meeting when you change shifts, so that the one doesn't infect the other. What to do about the shared premises where people eat? How should employers pay attention to these new strains? What should they do? Well, we've heard it already, so I repeat it. Regardless of what strain of virus is circulating, we need to be very alert. And employers who need their operation maintained, and they need the people in the workplace, they've already been doing it. And we are talking about schools as well. It doesn't really only concern companies. There's a vision that education process will be renewed when we get from the worst situation, So perhaps we will start reopening as a society. And the key is frequent testing on enabling sufficient number of people who are infected, capturing these people who are infected. And this can be set up according to the situation in the given region, the epidemiology situation in the given region, or the situation in the given organization. So this is the COVID semaphore, the traffic lights. Yeah, yes, this traffic light is the basic thing, but every single organization should be able to set the rules and measures according to their own needs, implement continuous testing, regular or according to their own needs, and based on the results of this testing, they can apply the intensity of measures and the frequency of the testing itself. So naturally, you can influence what you mentioned. Increase carefulness, being more alert in shared premises. And again, it is nothing else than minimizing of contact. And if the contact is inevitable, then the person or the persons need to be sufficiently protected. And this is the same thing again, respirator or face mask or a face shield, depend what sort of contact this is. Would you recommend employers to buy respirators for their employees? Well, respirator is efficient tool to filtrate the air. I mean, the quality surgical face mask, just like the one I am wearing, is a very efficient has a very efficient mechanism for filtration because the middle layer is sufficient enough. There are 3 layers in this face mask that I'm wearing. So essential orientation recommendations. The face mask or respirator must be certified in the EU. And if you follow this, you are pretty safe. Of course, the respirator is a little more efficient. A respirator that you are wearing, for example, is more efficient or is a slightly higher level than a quality surgical face mask. And of course, wearing it on your nose and not under your nose. Mr. Danko, we'll be talking about the testing in more detail, but we've heard the antigen testing, because PCR testing, we don't have capacities for that, I mean, in all factories. So how frequently should the companies be testing? What's the reasonable level? And what about the antigen test reliability? Because you have antigen tests, you go to PCR, and you have COVID. So what does the negative certificate from antigen test mean? Yes, you're right. The certificate or negative antigen test doesn't mean that you are certainly COVID-free. I mean, PCR tests are much more sensitive, yes, but their availability is lower. And the antigen test is very easy to perform. I mean, you have result within 15 minutes. When it comes to antigen testing, it's a very good instrument for employers, because it is less sensitive, but it can capture the highly infectious patients, the super spreaders. These are most risky individuals in this collective. So I don't want to say that person who has fewer viruses are less infectious, but these super spreaders must be excluded from the collective for this period of time when they are infectious, and the antigen testing is ideal for that. But what about the frequency of testing? How frequently should we be testing? We have the nationwide testing ahead of us, or it's already running, and someone took a test on Monday, and his or her antigen test will be valid for, well, incredible number of days. I mean, to make sure it's effective, how frequently should we be actually getting tested? Every week, every 4 days, or every other day? Well, if I may comment, large employers have been testing continually for several months already. And the situation is developing, just like the epidemiological situation is developing. So under current conditions, at least those that I communicate with, test their employees once a week. And in case the situation gets worse, so there's a increased positivity of tests in their organization, then the testing is more intensive. They test, every 4 days, etc., etc. And they continue until the situation improves. Just like Mr. Danko said, the tests are different. PCR test is golden standard, but antigen testing has a great advantage that it can be performed very quickly. It's more available, more accessible. So there are several factors to consider. Since there is a greater degree of sensitivity, people with positive results can be retested by PCR tests if available. Then, of course, it's a question of the return to employment of an employee who was in quarantine because he or she was tested positively in PCR test. Then he or she doesn't have to participate in testing for some time. Yeah, that's another question. You said that strains are redefining COVID-19. So how does the situation change when you have an employer who is testing their employees every week? And so far, they didn't have to test the people who were post-COVID patients. So should this be redefined? And should you also include these patients in testing? Yes. They should pay more attention. I totally agree with that. At the moment, no one has already performed any specific changes yet, but it's something you need to expect for the future. If this is confirmed, that the rate of reinfection is higher because of these new strains, then employers need to take this into account and to react accordingly. There's one more question that comes to my mind. We were talking about infections through spaces and surfaces, and then we said that the aerosol is much more dangerous. Is this change because of these strains? Of course, we all wash our hands and we disinfect our hands, but are these strains more dangerous also because of surfaces? Well, not directly. The surfaces are not more dangerous. Maybe indirectly, meaning if people have more virus in them, so if they contaminate the surface, also the surface has more viral load than previously, but it has nothing to do with the infectiousness of surfaces as such. So surfaces are a minority threat. They comprise less than 10% of infections, just like previously. Yes, I'll just add, in order to be infected through a contaminated surface, there need to be a coincidence of several factors, or several accidents, which usually don't happen. So not just briefly before you touch the object, someone had to spit on it, metaphorically speaking, but I need to immediately or soon enough touch my eyes or touch my lips. And this is not really happening because people wash their hands or disinfect their hands very frequently. So the risk of infection spreading through contaminated surfaces is rather limited. Mostly it's aerosol. So we had this brief survey among our viewers whether they are planning vaccination against COVID. Do we have the results, continuous results or preliminary results? 92% says yes, 8% undecided, need more information. I'm sure we will provide. And nobody said no. That's a good news. That's good news. I guess we have the social bubble here, operational. Nevertheless, we have one more survey for you, because we're going to be testing more specifically about testing. Are you testing your employees on a regular basis, testing for COVID-19, of course? So that's another question. You can also join with your questions. Slido.com, hashtag COVID testing. You can see the hashtag right behind us. I think behind Mrs. Brazhinova's back. So I hope you will join us with your questions. We will certainly put your questions to the speakers. Let's talk about the tests. Mr. Danko, how would you expect this false positivity of antigen testing? This is something that people ask a lot about. There's a percentage of people who have false positive tests. Why this happens? How would you explain this? Let me explain this way. You know, testing or nothing in the world is perfect. Nothing is 100%. And I'm quite convinced that the virus is not 100% either. So first we speak of sensitivity of the test and specificity of the test. So how specific and how sensitive the test is. And there's always some space for false positive result for the given individual. But what it means in a layman language, I may have a different virus and the test evaluates this as a COVID or coronavirus, or what it means. Because when you say that usually you would expect false negatives, but the tests are more frequently false positives, and people don't understand why. Well, you have both cases, false positives and false negatives too. And this applies for all tests, right? And, well, it can be a different interference from other viruses, as you said. So there are other coronaviruses here that are not, they're not very often mentioned, but there are other coronaviruses than the novel coronavirus. So all the things can interfere. I mean, you remember this famous or infamous research with Coca-Cola, but it was poorly interpreted and poorly performed. Nevertheless, yes, we need to realize that the test can react to some chemical substances in your body, and the result can be false. You know, with antigen tests, you prove the presence of one single protein of the virus. And the proof is based on a on the binding on the antigen. And antigens, in general, often are somehow crossed. So there's cross-binding. And it can bind to a substance which doesn't actually represent the coronavirus but something else. And then the test seems to be positive. And these can be other coronaviruses, not the bad one we have. But according to normal, in normal conditions, you perform the test in validation studies, and you examine what are all potential substances giving you cross-binding or cross-reaction. So besides other coronaviruses, like coronaviruses causing rhinitis, which doesn't always react in this cross-binding, but it can be a para-influenza virus. It can give you this cross-binding. Or it can be some other factors that result in this binding with the antigens, and there's a false signal. But in general, most antigen testing, those that are quality antigen testing, and when the testing has been intensive, you have the rate of non-specificity that is rather very low. Moreover, antigen testing from various producers, manufacturers, differ slightly in terms of their quality, in terms of their specificity. And the factors leading to false positive or false negative result are numerous. Of course, what Boris said is true, but there can be also the circumstances of the collection of the sample that can influence the false results. And what we need to remember what is the time window for capturing of the virus load of the antigen testing, meaning what period after being infected the test is able to capture the presence of the virus. You know, the antigen test is covering a smaller time window, while the PCR test covers the wider time window, including after 10 or 14 days, sometimes even 2 months. So can we simplify this by saying that if someone has symptoms, he or she will certainly be captured by antigen testing? Is it like that? Well, to simplify this, a person who has symptoms is very often positive on antigen testing. A person who has no symptoms doesn't have to have positive antigen test because he or she can be in the period right before the virus has multiplied for a sufficient number that the test is able to capture, or he or she can be after this period of top period or peak period where the number of viral particles is on the decline. Yes, it's true. Ideally, the test would capture you, but a number of validation studies which are performed after the fact with countries or institutions, you know, these validation studies are often performed on symptomatic patients or patients who are indicated, so patients who have some reason to be tested. Yeah, and despite the fact the rate of sensitivity is around 60 to 70%, 60 to 70. So quite obviously, there are people who have symptoms and they are not captured by the antigen testing. That's a fact. Well, nothing is 100% perfect. We've already heard that today. Perhaps every drug or every test have a certain degree of success rate or efficiency. So, what about tests of the future? We have antigen testing, we have PCR testing. It seems to be working on the mutations. We don't have to update it profoundly. But many people say we would like to have a PCR test which is simpler. We'd like to have sort of this gargling test, so to say. What's the status quo in terms of simplification of the testing and how difficult it is to develop a test? So I'll start from the back. Development of a test is not easy, right? It's complicated, but we have a rich data. Science has a lot of data in general. So it wasn't so difficult at the beginning to develop the test. We are quite successful in this, but not as successful as to defeat the virus immediately. You know, at the moment we have available machinery in Slovakia performing PCR tests that doesn't require isolation, so there's not so much manual work requiring several hours, because a standard PCR test takes several hours. You need to isolate the specimen either manually or in the laboratory, and then you can only perform the actual PCR testing. And we already have tests available in Slovakia which, well, you only add the specimen and it all is done automatically, and in 20 minutes you got the result of a PCR test. And you even have you can even differentiate whether it's flu A, flu B, or COVID. So these are very rapid tests. 20 minutes is a very good turnaround time, and very precise turnaround time. So the development is advancing. All companies are trying to do this to make it as simple and as quick as possible. Will we perform antigen testing at home? Yes, in the future we will be able to do that. Before the start of discussion, I asked whether the test must be done by medical personnel. Well, it's not. It doesn't look like something very highly difficult. I mean, maybe a lay person could do that. Ms. Bražilova, why a doctor or medical staff must do that, and why a company cannot just train a team of individuals performing the testing, and they need to ask medical staff. Well, yes, this is the setting so far. The collection of the sample must be done by a medical professional. Well, we are, entering the cavities of a human body, where in most cases, well, nothing happens, but there are cases, very rare cases, there can be some complications, some bleeding from nose, or some scratching of a mucosa, or something else. Or sometimes even people can faint. So this is the reason why we set it like this. Of course, with the developing situation, also here we see from capacity reasons, it would be really good if this wouldn't have to be done only by medical staff, because medical staff is extremely busy in hospitals and offices, medical offices. So getting the load off their shoulders would be really useful, but the person performing the testing must be sufficiently trained. It can't be done by anyone. So can you imagine, just like today you have a training of first aid, so would it be possible that you have a certified training with testing taking, I don't know, several hours or several days, I don't know, and will it be done officially with a certification? Yes, exactly. This is our idea, and this will be ideal situation to start certified trainings for personnel testing. And of course, who's going to coordinate the trainings and who will be responsible? That's a question to be answered. But generally, yes. Mr. Klempa, isn't this isn't the fact that the medical staff is doing this today, but there are also students, and not all of them are well versed in working with cavities. I mean, isn't this argument for testing by a lay public? Well, yeah, I agree that this is the way to go, or it's the path to be taken. I mean, this could be linked to the first aid training. If you have a first aid training, you can have also a training module about taking swabs from mucosa of the nose, So I have a practical question. If there's some company that is planning to introduce testing in its organization, how important is it that it's done inside, outside? I mean, with the windows open, with windows closed. How to do the testing in companies. From safety reasons, it's always better to perform it outside, in outdoor environment. It's fresh air, etc. Of course, you cannot do this when it's winter, it's cold outside. The conditions are very far from ideal, even for the tests themselves. You are using fluids. Just the essential physics says that a frozen fluid, even if you put the specimen on it, will not work. So the test also requires an ideal temperature, and it's definitely not in freezing temperatures. So yes, you need to select some rooms for sample collection that correspond with the recommended rules recommended by WHO or the Ministry of Health, right? From the practical perspective, we've been testing the students of medical faculty so that they could perform the test. We've also gone through some development. We were testing in tents outside, in outdoor environment, so that we minimized the risk. But exactly as you said, it's winter, and we know a lot about how to minimize the risk. So we perform the testing itself and the processing of the samples indoors. But there's one more step when you need to clean your nose. As a tested individual, we do this either outside or in very severely drafted premises, and then the individual enters into the place where the test is actually performed. and this can be done interior. So you can separate the steps to minimize the infection. Well, this was interesting also for the chief pathologist in Slovakia, who said that originally they were all wearing these testing clothes, and then they changed. So gargling is one more interesting thing or type of test. It's an ampule that each child will get. She will gargle, or he will gargle, send in the specimen in the ampule, and then it will be sent. So is it one single PCR test for one class, and then wait, you need to be rephrased. I was participating in the pilot study, and the initiative came from us. So yes, with the gargling test, the differences in the type of sample collection is a standard PCR test, and the gargling has two benefits. First, or maybe more of them, but the first benefit is that you don't need medical staff assisting in the sample collection. Anyone can do it on their own. And it's perhaps much less unpleasant than the nasopharyngeal swab, which is a very big factor with children. Or maybe with parents who are very sensitive naturally in relation to their children. And the second big advantage is that the material gargled is easier to put together, and it's easier to combine the samples. And then the mass testing of the combined set of samples or specimens. So we want to combine the advantages of PCR tests with the better possibility of pooling of samples or specimen, which is very much supportive or instrumental in increasing the speed and mass testing. So the sensitivity is just marginally lower than the sensitivity of PCR of an individual test, and it's much more higher than sensitivity of antigen testing. So this was proven during the pilot test in 3 schools when we had classes gargling, and even the parents did it, and we also pooled the classes and the parents and their samples. And when the result is positive, you can test each sample, finding out which was positive. Well, with this pilot study, everyone parallelly also underwent antigen tests. So we could nicely compare it, and we saw that the identified positive pools always had, well, in 4 cases in particular, there was someone with positive antigen test, but we also had a pool where there was no positive antigen test. So everyone tested negatively. And when we tested them individually in PCR, it was confirmed that one single individual in the pool was positive. And we had 25 persons in the pool, and we were able to identify this single person. So this pilot study, which was performed or was organized by the intervention team of the Ministry of Health, together with health regions and together with us, the Biomedical Research Center. So this led to the decision made that this is also going to be performed at schools, this sort of testing. But now it has to be taken over by the large players, the companies that are able to perform large-scale diagnosis. And this means also some commercial sets for gargling, because we did it in really makeshift conditions. So people had this physiological medium or solution in their plastic glasses. They gurgled. It was combined. The specimen were combined in our lab. So now, if it's supposed to be performed at schools, it must be professional. So now is the time for manufacturers to to develop products, gargling sets for pooling of samples. And I believe this is going to be very attractive from, let's say, commercial perspective, because this could be also future also for the companies, right? That you just give the gargling sets to people, you just collect the samples. Yes, exactly. This is the way to go. This path should be very viable for companies. Of course, antigen testing have very good advantage of having the results immediately. Gargling is still logistically demanding, but there are other benefits. You know, in the world, the other companies or organizations are using. For example, Vienna University has a program where the employees of the Vienna University gurgle in the morning. They bring in the sample and all, even including their whole family relatives. And this is done on a regular basis. So they have the experience that they truly can capture the positive, even the family members, before the actual employee of the Vienna University becomes positive. So they are protecting their work environment from threat of the virus. Thank you. Mr. Danko, what we are talking about now is the future, or in terms of months. So we will be tested again and again, whatever the type of the test. But should people get ready for this alternative of getting nasal swab as an everyday part of our lives? Well, yes, in the closest weeks and months, for sure, because this is one of the weapons in the fight against coronavirus. The more weapons we have, face masks, social distancing, testing, the more we have, the more we protect ourselves and the whole society, our communities, protect from the spreading of coronavirus. Ms. Bražinová, politics aside, regardless of the decision-making, isn't this an advantage that we had a nationwide testing, that people already tried it and people are not afraid? Because we see the Czech Republic, when they are starting this mass antigen testing, and there's much more resistance of the population. People don't want to go get tested, they are afraid of it, and people here, they've been tested, they're not afraid anymore. And isn't this psychologically a good step, politics aside? Of course, this is an advantage. Even the self-governments who organize their own collection points, they know how to do this because they've already tried. Politics doesn't have to be aside, or can be, it doesn't have to be, but regardless of it, nationwide testing or regional across-the-board testing is certainly an effective and efficient tool to capture the infectious individuals, but it's just one of the tools. It's not a panacea, it's not a silver bullet. Yes, every expert says that. So let's talk about the final part of the discussion, and then we start with the questions from the audience. The vaccine. And what are the antibodies? Because strains aside, I know people who have overcome a severe type of COVID-19. They don't have so strong antibodies, or they have lower level of antibodies. Some people have more antibodies, some people have less antibodies. So what are the factors here? What's actually happening? How the body creates the antibodies actually? Because to a lay person, sounds like the more difficult COVID-19, the more antibodies, right? Yes, basically, this applies generally. This correlation does exist. The more difficult disease, COVID-19 disease, the more antibodies your organism contains or develops. We saw it in our research, and this applies that the weaker COVID-19, the higher likelihood that you as an individual don't have the antibodies. And this is basically a snapshot. This is just a snapshot of a single moment. So at the moment, you might not have antibodies, but maybe you did have antibodies in the past because you had only light COVID-19 course of the COVID-19. So maybe the antibodies are under the detection limit they were able to capture. And this is basically how it works in biology or in nature. We're not all the same. The rate of difference is simply just high, or there are large differences. Some organisms react differently than others. That's an absolutely normal thing, and there are no axioms here. I mean, you had this course of disease, you will have this and this amount of antibodies. This is basically why we do the tests. Okay, so a question from me. Imagine I had COVID over the Christmas, but I had no fever, I had no symptoms, but I was tested positive with very light disease, very light course of the disease, and doesn't mean that I could be running across the country pretending I'm immune, right? Exactly. Well, it certainly doesn't mean that you could be running around or meeting people and you cannot pretend that you are immune, or you cannot pretend that you are risk-free. The so-called post-infectious immunity is, to a great degree, very individual. There are even people who never develop post-infectious immunity. And just because of this high variability of this post-infectious immunity, we have to recommend people who are post-COVID patients to get vaccinated. It's a very strong recommendation. So even though you can have antibodies after your infection, we know already from a number of studies that the level of antibodies is declining. And how quickly it is declining, we don't know because, well, we do know, but some studies say 3 months, some studies say 6 months or 8 months, but these specific antibodies do decline. And despite the specific part of our immunity, we have the so-called cell immunity response. And this, to a great degree, persists for a longer time, but we don't know how long. Because this is still under research. We are researching this. And this cell immunity in research conditions is monitored, but so far we don't have diagnostic tests for this particular part of immunity. So let's look at the results of the last survey. So these are the questions, but I want to ask about the questions from the audience, but we want to have the results of the test. Waiting for the response. Well, okay. Before we see the questions, let's look at the last topic, the vaccine. Mr. Danko. Okay, we have the results here. So 79% doesn't test. Okay, the total number of votes is only 20. So nevertheless, 80% of companies do not test their employees. So the vaccine. Many people are afraid. They say it was a rapidly developed vaccine. They're afraid of the consequences. A lot of hoaxes about vaccination. A number of legends about pharma companies. You are a pharma company representative. What would you say to calm people down? Is the vaccine safe? Would you get vaccinated? Well, our company doesn't have a vaccine, so we do not deal with this particular field of medicine. But the legends are about all pharma companies. Well, yes, of course. I would personally and I will get vaccinated as soon as my turn is, well, according to the state model. And when it comes to the hoaxes and legends, you can read anything about the internet and vaccine, but this is a controlled, approved vaccine by the European authorities. It's been approved also in Slovakia, so you shouldn't be afraid. You shouldn't be afraid. I know that you don't manufacture vaccines, but you manufacture tests. You have other pharmaceutical products. The control is quite strict, right? It's not like you come up with something in your lab and then you inject it to people. No, of course not. Well, especially in this era, this is so strongly followed topic. It's under scrutiny. No one can actually, no, let me phrase it differently. Everybody follows this topic. It's scrutinized, absolutely, so you can't afford importing something that is not thoroughly checked. And this applies to tests and the vaccine, right? You need to look at the test. How many clinical studies have been already issued? I mean, the precision of the test or the specificity and sensitivity can differ. But I've seen even 100% tests. But there are no clinical studies behind that. So, yes, you need to check that. And the same applies to vaccination or vaccines. Yeah, I can only add that the clinical trials or the whole process of the development of the vaccine is live, literally, in real time, like never before. These are new things. And it's all connected to all of us being extremely tired of COVID. And the degree of COVID fatigue and fear and concern is much higher. And also highly professional and very much expert topics are now discussed by lay public on social networks. And there's extremely high number of misunderstandings. And I absolutely understand the fear and concern. I do, because we are experiencing a massive advance of new technology and vaccines, but these were developed exactly to be able to provide rapid response to these epidemics. And they were developed to be safer, to stimulate the cell immunity response, and now we are collecting the fruits of this labor, which certainly did not start in January. The research in these technologies has been going for many, many years. But unfortunately, one part of the public believe into things that are just not true. I mean, it raises concerns and fears which are natural, and we're trying to explain that it is ungrounded, even though it's natural. And I'm very happy about the vaccination and about the fact that the vaccines have been developed. And I agree with what's been said, that the whole development is under such a strong scrutiny that you can't even imagine. Every single person that dies after vaccination, the whole world knows. And this great number of this slight partial information that we are bombarded by basically contributes to this fear and concern. Of course, you cannot compare the development of vaccination 40 years ago and today, because medicine has been advancing, just like you are able to develop new technology in ICT, like smartphones and computers. It was hard to imagine 20 years ago, right? So the advance of medicine is similar. The health minister said, the Slovak health minister said that they conducted some surveys, and that the willingness of the president, for example, to get vaccinated really resonated with the public. Is this good news? Well, certainly this is good news. The sociologists and psychologists know that when people see role models in society, they are more willing to follow. This influences their behavior. So yes, this is good. But let me finish on the safety of vaccines. Yes, this vaccine was developed much faster than the other vaccines, but it was because it wasn't developed on the green field. It used already developed technologies, and the administrative process was drastically cut because the whole world needs the vaccine. But the clinical trials on individuals, on humans, was exactly like any other vaccine, on the exact same number of people that it should be. So the testing of safety and efficacy of the vaccine was not shortened, was not accelerated, wasn't limited or restricted, and every vaccine has been tested on tens of thousands of people. Final question: what's the prognostics of the pandemic? We have the second wave, we have the vaccine, but lack of it. the process, the manufacturing process takes some time. So what's your forecast? The forecast is that if we manage to vaccinate gradually the largest possible number of people, but I'm not talking about Slovakia only, but globally, we are no island on our own, we depend on other countries as well. I mean, it will take long months that there will be cases of infection and foci. The question is whether we will manage to vaccinate the most population. There will be endemicity of the virus. It will continue. But if we stay in the situation with the data that we know, I think we will return more or less into normal. I don't know when, hopefully next year, but it's very likely that we will be wearing face masks for some time. We will have to show your vaccination ID when we travel, when we perform a number of activities, but there's a number of other factors that can influence the development. We don't know what about the new mutations of the virus. So if everything goes according to the plan as the situation is, as is, until we are not all vaccinated, we'll be dealing with local incidents. And if most population got vaccinated, it would really help. So let's look at the questions from the audience. We have several. Everyone who is watching can join us, slido.com, hashtag COVID testing. So anyone who wishes to answer the question, just go ahead. So the first question, imagine you can change the communication of state towards the citizens in relation to testing and vaccination. What would you recommend? Well, none of us are experts in communication. And this is a political question too. I don't really like these questions, but I'm not afraid to say that I really like the way how the president communicates. I believe her voice and her communication is very soothing and calming, and her approach, I believe, really helps. She's calm, she motivates, she explains, and she doesn't want to get into conflicts with others. Ms. Bražinova. I believe that the fear and concerns are based in ignorance. So explain in a lay language, comprehensible language. You know, many people don't know the details of the virus or the vaccine. So it's good, you know, the infographics, which is already appearing, to make sure it is as comprehensible as possible. You know, there's always there's never enough, you know. There's never enough explanation. So the more the better. Yes, the more the better. Various channels, all the channels. Some people only watch TV. Others are only online. Others need to, you know, direct mailing, you know. So all channels. Anonymous questions or non-anonymous question, you know, just the possibility to ask questions. Of course, this is a difficult job, but it's the only way to go. Mr. Danko? I agree. The more we talk about it, the better. And use the simple language. Infographics. People are interested in how it works. Everybody wants to know about the future, right? So this is the information we need to provide. Okay, I think we are trying also through this discussion. Next question. Which vaccine do you think is the best at the moment? Well, at the moment we only have 2 vaccines in Europe that are approved. So let's only talk about these. Well, the best vaccine is the one that is available to me. Mr. Klempa, any favorite out of those 2 vaccines? Well, the 2 vaccines that are available at the moment, Pfizer and Moderna, use the same technology, and they are very similar. So there are only technical details that differentiates them that I don't even understand. I don't even understand. So I would definitely choose any of these two which is available. I wouldn't hesitate. Moderna has one interesting thing, that this window between the first and the second dose is 1 week longer. And I'm not quite sure if I understood correctly that this will have to be reflected in the reservation system. But otherwise, the differences are just minor and technical. So I wouldn't really be able to choose a favorite. Okay, approved vaccines. Yeah, they are approved and that's okay. If I have coronavirus, when can I return to work? This is a question that people from my bubble also have. That you have 10 days quarantine, but you still don't have taste, or you don't have fever, you don't feel bad, you have been in quarantine. So when can you return to working collective? Yes, the setting is that since the test result, you need to stay in quarantine if you don't have symptoms. If you have symptoms, you need to wait for the symptoms to disappear, including the taste. No, just acute symptoms. Fever, coughing, these slight symptoms like losing the taste in the nose and mouth, or light headache, they can persist for months, but it doesn't really mean. So okay, just fever, feeling sick, and coughing. Otherwise, it's safe to go to the collective, even though you still haven't recovered your taste and smell. After 10 days. Yes, of course, 10 days. Okay, Mr. Danko, how do you think the companies should be testing? When, where, and how to inform the employees about the test? Shouldn't the employees be waiting outside for the test result? Well, it very much depends on the setting in your company. You need to prepare, this pandemic plan, if you like. And what I can say, well, it's very good to have this pandemic plan at hand, so that you protect your employees. And face mask is mandatory. Social distancing and the disinfection, not spending, spending time in shared premises, etc. But until there's negative test result, the employee shouldn't go to the company, right? Because he could spread the virus. Yeah, logically. Well, I wanted to answer this way. It's also about the size of the company. I can imagine if it's a small company, we can provide that. If it's a large company where you have shift operation, I can't imagine that the employees are waiting outside. It's about the rules of operation of every single company. Maybe you can sit down with an expert to get some advice how to do that. Ms. Bražinova, I guess employers contact you on this. Sometimes they do. And if the person is in the workplace before testing, they can return to the workplace after the testing because they had been there anywhere. And then, of course, you tackle the situation depending on the result of the test. But if it's after some longer time, like the employees were at home for a holiday, or there was a company holiday, for example, and you want to avoid that the infected individuals spread the virus, then, of course, it is quite wise to organize the tests so that only the employees with negative testing return to the workplace. And of course, it very much depends on the number of your employees. Are you considering testing according to PCR tests approved in the Czech Republic, and you only need your saliva specimen, or swab from saliva on the tongue? It's all about validation. If this method of specimen collection is sensitive enough and it's been validated, then I wouldn't be surprised. So it's possible that something like this will be applied here, but so far I don't have any information about this. Does anyone? No. No comment. What's your opinion on smokers behaving like if there was no COVID. They stand in groups with no face masks. Shouldn't the state regulate this habit? Well, I think all smokers behave like this. I can see, groups of smokers in front of buildings, sometimes even during antigen testing. Yes, sometimes even during the testing. Well, what can I say? I mean, naturally, it's increased likelihood of spreading of infection. If I'm without a face mask, I am I'm exposed to infection, and I can infect my surroundings. That's a fact. Okay, Ms. Bražinová, Ms. Klempa, when it comes to vaccination, teachers are pretty low down the scale. How do you perceive that? Well, teachers ask me about this often. Yes, it's true. They are. Those phases have been renumbered, so now the teachers are in. There are 11 stages. I think teachers at stage 7. I'm not sure. I personally don't influence the division or breakdown into these stages. But if we have priority to open the schools as soon as possible, then of course teachers need to be vaccinated so that they are protected. So if at all possible, they should be, they should rise up in the hierarchy. Well, yes, but who shall we prioritize? Because we have sick people, you have seniors, you have people in the first line medical providers. So, who do you prioritize? Well, it's not about prioritization. It's not about jumping the queue. Ideal setup is that you perform the vaccination as soon as possible. According to my information, we have sufficient vaccines for 85% of the adult population. That's what the Prime Minister said. So we have sufficient number of vaccination points. There will be some new vaccination points. So if we can accelerate the process of vaccination, we should do it so that everyone is vaccinated in the next couple of months. That would be ideal. How do you perceive efficacy of surgical face mask and a textile face mask at the same time? It's useless. It's useless. If you have a surgical face mask, you don't need to add another face mask on it. Okay, good. If I am PCR tested positive, but I have no symptoms, when can I return back to the collective at work? 10-day quarantine. 10-day quarantine. 10 days after tested positively, you can return. If you have no symptom, if you are symptom free. Mr. Danko, you're testing in your company too. What would you advise us to avoid? Yeah, we do test in our company. We have a lot of people in home offices because many of us have office jobs, even though we are a pharma company. So it's good if the company can operate on home office. So we give the employees the possibility to get tested. So they arrive, get tested, and they go home. What to avoid? Well, I believe testing helps to capture the infected individuals. I mean, the more often you do it, the better, but you can't do this every day. Yeah? So set the rules. Set the rules for all employees to get tested. Maybe one practical comment. It's a widely discussed thing with regular antigen testing. Even people who are post-COVID patients or people and return to their employment, they should still be included in the regular testing so that you don't apply across the board that you don't need to get tested 3 months after the infection, If it was only antigen testing, this person should be continually subject to testing also. How would you compare the efficacy of vaccines based on mRNA from Pfizer and other vector or adenovirus vaccination, like the one from AstraZeneca or attenuate virus. The published data on efficacy of mRNA vaccines is around 99%. This is the maximum we can achieve. I mean, I can't even imagine more because we are really different. So a certain percentage of the people will always be, for some reason, they fail to respond to the vaccine, however good the vaccine. So 95% statistically is almost perfect efficacy of a vaccine. From this perspective, the mRNA vaccines put the benchmark extremely high. So anything under 90 sounds like crap, which is very far from truth. And it's true that the clinical studies of the adenovirus vaccines from AstraZeneca, the figures are not so amazing compared to mRNA, but we also need to explain. It is important to define what is a single case and what is the objective, whether it's preventing the infection as such, or preventing a severe infection, or preventing death. So it depends on how you define the objectives, and then the percentage or rate of success can, fluctuate. And the vaccine from AstraZeneca turned out to be, maybe coincidentally, that it requires lower small dose, and it results in a better positive effect. So the group which by mistake received the first dose with smaller concentration, the efficacy was almost 90%. But since this was a mistake, it wasn't planned, so this group of patients had it wasn't representative demographically, so we cannot say it's a final result, so it needs to be tested. So what I want to say, despite the lower percentage of the vaccine from AstraZeneca, I believe it's going to be very important because of its availability, because of its easiness of transport. Yeah, it says, we hear that this is going to be very useful for remote locations. For example, well, maybe this is not relevant for Slovakia, but in the United States you get deserts or places where you have to travel for hours, so it doesn't require such low temperature, etc. Yes, exactly. It can be administered just like any other vaccines that we were used to. So your office-based GP can give the vaccine to you. A number of poor countries or tropical countries where the freezing temperatures are, very difficult to achieve. So, by the way, the economic differences also show in the rates of vaccination until all the continents are vaccinated. And there was this attenuated vaccine. Just to explain, of the vaccines that are planned or contracted that should be imported here, none of them is attenuated vaccine. Attenuated vaccine means that it's a live virus which is somehow weakened, just like the flu. No, not even flu vaccine is attenuated vaccine. Measles are, right. Historically, the white fever. So no one is going to get injected coronavirus. Exactly, that's the point. There's no vaccine like this. And in these attenuated vaccines, they are attached in kickstarting the cell immunity because there's small, limited infection taking place in the organism. But this deficit should be eliminated by mRNA vaccines or adenovirus vaccines, because they simulate infected cells in our body, and the body then develops immune response. We have last 10 minutes, so Mr. Danko, do you also alternative tests, the gurgling tests? We have various types of tests. We deal with the lab testing. just like the antibody tests. So people can also test for this, but this is from blood, and then of course antigen testing, PCR testing. Gurgling tests, we don't have that many at the moment, but it's only about the method of sample collection. The test itself, but only the sample collection kit is different. Okay, this question has already been answered by Mr. Klempa. Can you imagine testing at schools? Whether this is unreal? We've already mentioned the gurgling. Yes, it's real, and the Ministry of Education is preparing specific steps to perform this. I was called to this as a professional supervisor, so let's keep our fingers crossed so that there aren't any complications, and we'll do that. Just one comment. Regardless of how quickly you launch these gurgling tests, schools are also preparing for an alternative to start sooner by testing through antigen testing. They already open the sample collection points for testing so that they are ready for the moment when the Minister of Education says that we are starting. So there is a plan that schools should be opened from early February, so we will see how the epidemiological situation develops. By the way, yeah, the British strain is more dangerous in children and young people. What would you say to parents who don't want their children to be tested using this swab? Any advice to these parents? Is it dangerous for the children? Can the children manage? Let's try to speak about this. It's not dangerous. This swab is not done to small children under 3 years of age, but children of school age. The process is the same as in adults. It's not dangerous. The only thing is that it may be unpleasant for some people, just like to adults. Yeah, it's interesting to see that the schools are very connected, and schools and employers are very strongly connected. In this respect, of course, in the Czech Republic they have these traffic lights, but the situation is truly terrible there. I'm afraid that this traffic light scheme can only serve to false hope. Well, this is not my domain. But as far as I know from my colleague from the Czech Republic, the problem of the Czech Republic is they have this PES system. The problem is not in poor setting, but as soon as they're supposed to get stricter in the restrictions, they started to release them. They started releasing the restrictions too early, so they basically don't have the restrictions, and that's why it's not working. Ms. Bražinova, when we launched the automat, the so-called traffic light scheme, is it possible that politicians are afraid that someone somewhere in the region gets angry and starts to demonstrate? I mean, is this the key aspect? Yes, it's very important. But also, we need to say that the COVID traffic light scheme is flexible, because we already see, depending on how it's set up already, the schools are opened after skiing resorts, and maybe we should redefine the priorities. Yes, we should redefine the priorities, because I've said it several times already. The situation is developing, and we need to react. When the automat was being set, the situation was different than it is now. I want to test in my company. What should I do? I think we've answered this. Well, if someone wants to briefly answer. We've said that you need to implement a system. You need to implement a system that the whole company follows. Yeah, prepare a plan, follow the plan, stick to the plan, have some defined objectives, purchase the tests, and then put together a sample collection team, and then do the testing and test repeatedly. You said every week, yes, every week, to capture the all the infected individuals or most infected individuals. Final question, I think it's been answered already. When do you think schools will open? Oh, I don't dare to say this. I think they will open in February, or they will start opening in February, but it's possible that after some time they will be closed again. It's possible, because what we've seen previously, 2, basically, or maybe 3 waves, this is going to be repeated because it totally depends on our behavior. So until we get to the good situation, maybe there will be some waves, ups and downs, and the schools will have to react to that. So do you think it's going to be regional according to the automat? Yeah, mostly, yes. If the situation deteriorates across the whole country, then of course there will be total lockdown and all schools will be closed. So let's keep our fingers crossed. Thank you very much for the timely and interesting discussion. Alexandra Bražinova, epidemiologist from Comenius University, thank you for coming. Patrick Danko, ROCHE Slovakia, thank you too. And Boris Klempa, virologist from Slovak Academy of Sciences. Thank you very much. Thank you for your attention. Today's discussion was, I believe, extremely insightful. We've learned everything essential in relation to COVID-19. Thanks for AmCham for organizing this in cooperation with ROCHE. My name is Zuzana Kovačić-Hanzelová. Looking forward to meet you in the future. Stay safe, stay isolated, and hopefully we'll do fine soon. Goodbye.